Good afternoon and welcome to today's webinar, Data Sharing Strategies to Advance Health Equity, brought to you by the Network for Public Health Law and the American Society of Law, Medicine, and Ethics. I'm Charles Trong, the Digital Marketing Coordinator at the Network for Public Health Law's National Office, and I'll be your host for today's webinar. The presentation slides and video playback for this webinar will be available on the Network for Public Health Law's website shortly after the conclusion of this event. We strongly encourage attendee participation in our webinars and would love to hear some of the thoughts and questions that you have, so please feel free to submit them at any time by using the Q&A tab on the right-hand side of your screen. To submit a question, all you need to do is click on the Q&A tab, select all panelists, and hit send. Your moderator and the first presenter of today's webinar is Jennifer Bernstein. Jennifer is the Deputy Director at the Network for Public Health Law's Mid-States Region Office, where she provides legal technical assistance on a variety of health topics. Her current work focuses on public health data, adults at risk, maternal and child health, and statutory and regulatory public health. The second presenter you will be hearing from is Sally Malam. Sally is also a Deputy Director at the Network's Mid-States Region Office and has over 25 years of experience in HIPAA and general privacy areas of public health. She is a certified information privacy professional with U.S. and government privacy certifications, and she has worked extensively with state agencies on health data issues. Finally, you will hear from Dr. Daniel Barth Jones. Daniel is an infectious disease epidemiologist at Columbia University, and he specializes in statistical disclosure control implementation under the HIPAA privacy rule provisions for de-identification. His work is focused on the importance of properly balancing competing goals of protecting patient privacy and preserving the accuracy of scientific research and statistical analyses conducted with de-identified data. So those are your presenters for today's webinar, and so without further ado, I will pass the baton off to Jennifer to lead us through the rest of today's webinar. Jennifer, over to you.
Thank you, Charles. I'm going to be acting today as moderator for questions and just doing a brief introduction, and then we will move on to Sally and Daniel's presentations. So for data sharing for public health has a very important role, and there's a lot of benefits to data sharing. Some of those include faster response time to emerging public health threats, easier evaluation to design interventions and determine best practices, greater collaboration between sectors and across jurisdictions, including state, tribal, and internationally, greater coordination of care, going back really thinking about data sharing between sectors and providing greater coordination between those. Also, identifying and addressing upstream social determinants of health. There are some common foundational considerations that we think of in regards to the ethical principles for data sharing. Those that come to mind most often are usually autonomy, privacy, and individual rights. These are all very patient or client-focused, thinking about the individual and their personal rights. But when we are considering data sharing for public health purposes rather than medical purposes, then we have to also consider broader principles like those enumerated by the World Health Organization. And those include things like justice, which is an acknowledgement of a fundamental right to health for everyone. Beneficence, which is a moral obligation to act for the benefit of others, helping them to further their important and legitimate interests by preventing or removing possible harms. Also thinking about common good, acknowledging that benefits provided by public health activities cannot be subdivided into individual private benefits like we would see in healthcare. And that's because those public health activities are fundamentally shared. And then equity, identifying the particular problems of disadvantaged populations identifying the basis of unfair differences, especially in health, and the developing focused health campaigns to address those inequities. Again, a very fundamental function of public health. And finally, reciprocity. That's an acknowledgement of a mutual obligation to exchange information for shared benefit. All of these ethical considerations have to be balanced against the more common foundational principles that we see most commonly cited in the healthcare arena of autonomy, privacy, and individual rights. And so finding that balance can often be challenging, and so the speakers will discuss that a bit more in their presentations. And then I wanted to just mention Public Health 3.0 and its focus on data sharing requirements. So Public Health 3.0 requires access to timely, reliable, and granular data, which goes all the way to sub-county level, and specifically that the data be actionable. Also depends, the data, or Public Health 3.0 depends on data from many and diverse sources. So these are not just sources from public health itself, but thinking about cross-sector and cross-jurisdictional data. This includes sources and types of data that are specifically relevant to social determinants of health. And that we should have data that is accessible to communities throughout the country, and that they're shared, linked, and synthesized, while also balancing those interests that we just talked about: security, privacy for the individual. And then needing a clear metric to assess impact and document success. So with these, we can see those World Health Organization ethical principles being expressed in the Public Health 3.0 matrix. And then Public Health 3.0, from those requirements, it really envisions that public health leaders will step up and act as chief health strategists for their communities, that public health has a special legal status, to collect, prevent, and control disease, protect the public's health, and promote wellness. And then also, as mentioned before, looking at multiple sectors as well as not just public, but also private partners as well, and health and non-health sectors. And finally, that the partners are coming together explicitly to address upstream social determinants of health. And with that background, I will now pass this on to Sally.
Hi, everyone. It's nice to be with you this afternoon. And I am going to have to apologize in advance. I have a cough, and I anticipate that I will probably have to cough during this presentation. So please bear with me. So Jennifer laid some beautiful groundwork about why data is important to public health, as well as de-identification. So let's talk about why we, first of all, are doing a webinar on de-identification right now. We just launched a toolkit on our website that has a lot of information that we hope is going to be useful to you. It has examples of where using de-identified data made a difference. It has toolkits, and it has resources. And we have the link there for you, and we have some information on how to get to that link. So if you haven't checked it out, I hope you'll look at the website and look at the toolkit and let us know if it's useful, what's missing, and how we might make it better for you. So we'll start with some level setting around de-identification. And de-identified data is very important. It's a fabulous tool to make data available to communities. And it's appropriate when the communities do not need more granular data. So when de-identified data is needed, it's really critical to be ready to respond to that request. And many times law might offer a specific approach on how to de-identify the data, or it might be silent. It may only require that the individual's confidentiality be maintained, but not give real specific guidance on how you would disclose that data. At a very high level, de-identification in essence means removing those direct identifiers like name and social security number that just jump out and identify and link the data to a person. And it typically also includes removal of those indirect identifiers that link to a person, such as date of birth and address. So what next? Well, when you're in public health and you receive a request to share data, where do you start? And so we know we need to start with the facts. There is so much to collect. We have put together a toolkit that goes through all of these different questions that you're seeing pop up on the screen here. And it's got a full list here called the checklist of factual information that goes through all of the different questions that you need to cover. When you look at a request for data sharing, most requests really are not the same. The question could involve oral, written, or electronic data. Some of your responses may have to do with whether you even have legal authority to collect the data or access it or share it. And if you do have authority, what are the conditions and limitations for the data sharing? In addition to law, there may be policy and ethical concerns that are relevant. You really have to understand, fully understand every facet of information sharing around this data request so that you're positioned to then move on to evaluate what's in front of you. So this checklist that we have on our website, and the name of it is in the white box on your screen, is designed to help you gather all of that information so that you are positioned to evaluate whether or not you're able to release the information. So next, once you have all of your factual information, you have to figure out what laws apply and what your options are. So you can see we've got a lot of different transfer points on this slide in this Metro diagram, and that's to remind us that at every data transfer point that there's an opportunity to have different law that governs the data source as well as the data itself. So when you look at our checklist, and the name of this tool is there in the green box, it's called Checklist of Review Criteria, and you'll find that on the website. It will step you through the different kinds of questions you need to ask so that you'll know if law allows the de-identification and if it has any conditions or limitations or prerequisites. So it asks you if you've identified all of the laws for each data type and each source. And you'll find, and as many of you already know, laws can be general and specific. They can be operating at both the federal and state level and applying to a single point of data. Every single transfer point of data is a decision point with regard to law, regulation, and policy. You need to ask if HIPAA applies. Sometimes it does, sometimes it doesn't. Your next question is, does law allow the disclosure of de-identification? Does it prohibit it? What does your Freedom of Information law have to say about the request? Does it require disclosure? does your law include any specific provisions for determining whether the data are de-identified or any standards that have to be followed? Does law require or does policy require a data use agreement? Are there any court decisions that provide guidance? There are just numerous questions that you need to make sure to review so that you can fully understand the limits and the bounds of what law allows. And this review criteria, this tool, is a way to help you remember to go through each of the steps. So this is a metaphor a lot of us have used for a long time about health privacy laws in the United States. They are an absolute patchwork quilt. And I saw this picture and I thought it was beautiful, so I included it. But sometimes when you're working in all of these different laws that on their faces seem to contradict each other, or at the least they're confusing, it never, to me, quite looks as beautiful as this quilt that I've put on the slides. But it's extremely challenging. You have to figure out which laws apply. Do you read them together? What do they say? Interestingly, most laws either do not apply to de-identified information or they permit it. But you can end up with a situation that may appear as if you have conflicting standards. So one of the first things you're going to want to do is to, as we talked about in the prior slide, make sure you understand all your sources of law and then work through which ones apply. And we identified a number of federal laws that have de-identification standards and put together a chart for your use, a tool for you. And the name of the tool is the name that's listed across this slide, de-identification as described by federal statutes. And it goes through a number of these statutes and provides you with a summary to the de-identification requirement as well as a link to the law. But we also have another really nice new resource that Jennifer's been involved with around federal privacy laws that provides snapshots of many more federal laws. So I would also commend that to your review as well. So this is a nice place to start for some federal laws. So in addition to federal laws, we also have guidance from the court. And courts often, well, there aren't a huge number of cases that interpret de-identification, but when the courts have interpreted de-identification, there was some commonality that kind of jumped out at me that I put on the bottom of this slide. But I would say as an overarching principle that one of my takeaways from reading these cases is to stress the importance in explaining exactly how the de-identification method utilized ties back to the law. And so that requires a really close working relationship with your data manager, your epidemiologist, your statistician, who is performing the disclosure limitation techniques or whatever methods they're utilizing to protect the data to render it de-identified. The court really needs to understand, and you need to be able to show the court, if it were to go to court, I should say you need to be prepared to show the court how the actions taken by your agency meet whatever the legal requirement is, because it seems that often if we're not able to connect every single one of the dots, the court is not going to be able to connect them either. It is very case specific. It is very fact specific. And so, again, it's so important to understand all of your facts and relate your policy, your de-identification methods to the law that governs your agency's data sharing. So now we're going to turn to HIPAA. And as I said before, and as you all know, not every single data sharing scenario involves HIPAA, but many do. And sometimes public health departments might utilize HIPAA as a best practice, or in some states they refer to HIPAA. So we've also created some tools that support de-identification under HIPAA, some quick references, so that you'll have them readily available to help you when you need them. The first tool that I'm going to talk about under HIPAA, and HIPAA has two ways of achieving de-identification. The first method is called an expert determination. That's someone like our Dr. Daniel Barth-Jones on the call with us today, and he will explain more about what this means, but just at a super high level, it has to be a person with the right level of knowledge and experience applying these scientific and statistical principles who makes a decision that the data that's being shared yields only a very small risk that an individual could be identified. They use a variety of mitigation strategies, and then they document the results of their analysis. And we do have information in the toolkit around a number of these methods. Safe Harbor, on the other hand, also a method listed under or provided under HIPAA, lists 18 identifiers that must be removed to render a data set de-identified. This method is known commonly or described commonly as a heuristic method. It's more of a rule of thumb. In this method, regardless of what the person requests, you must move 18 identifiers. It does not require an expert. And the covered entity, which is the healthcare provider that is performing the standard transactions electronically, or the health plan, and for a health department, that might be a lab that's billing electronically, clinic that's billing electronically, or a Medicaid division or CHIP. You cannot have actual knowledge that the information could be used alone or in combination with other information to identify an individual who is a subject of the information. Excuse me just a second. So these two methods that I've just talked about are known as technical de-identification. When you are adjusting the data to make sure that the individual in the data cannot be re-identified. There's also administrative controls that can be layered onto your technical controls to enhance your de-identification. You don't have to rely solely on technical controls. Examples of administrative controls are on the screen. You can also do some auditing to see if the data recipient is using the data for an agreed upon purpose. Has the data recipient completed a certificate of destruction at the end of the term of the data use agreement? There are numerous administrative or governance or management controls that you can put in place, and the stronger your administrative or your governance controls, the more risk is mitigated and the lower the risk overall of re-identification. So you can use administrative controls to bridge any gap between technical controls and the state of de-identification that your policymakers, your courts, or your agency, whatever that level needs to be. In fact, in a 2012 report, the FTC supported this approach and stated that the combination of reasonably good technical measures as well as good administrative measures likely leads to a lower re-identification than stronger technical measures acting alone. And they referred to HIPAA as a stronger technical measure. So we get to count these administrative controls when we think about risk. And for public health, this is really big. In the absence of a law prohibiting it, balancing data releases benefits for the good, for the public good, against the risk of privacy harm in a particular situation allows public health to use a combination of administrative and technical controls that best suits the scenario. This is a two-pronged approach. You can see the administrative controls really are the icing on the cake, as I like to think of it. So we would use both to give public health the ability to release richer and more granular de-identified data. And so, as I said, Dr. Daniel Barth-Jones, who will be speaking next, can help us better understand more about this approach. We also have a very robust section on resources. We have links to the HHS Office for Civil Rights website on HIPAA. One of the nicest features of their website, I think, is their FAQ section. You can type in just a few words about your question, then you can pull up easy to read questions and answers, and then citations, which will lead you to the applicable regulation. There are on this resource sheet also primers and white papers on de-identification generally. There are more specific ones in areas like for research. We have sample policies and procedures from state health departments and others. We have information on open records laws and freedom of information laws and data release. And we also have links to state data release laws. This is one of those areas where we really tried to gather up everything that we thought would be helpful to public health, and are very interested if anyone has any links that are not on this resource sheet. We would be happy to know and very open to adding them. And with that, I will thank you, and I'm going to pass the baton to Daniel Barth-Jones.
Thank you. Okay, let's go ahead and move into my portion of the presentation. I work mostly in the area of expert determination within HIPAA, and that will kind of color the way in which I present these results. I think they apply quite broadly in this context as well, even if you're not bound by HIPAA. There's certainly a lot to be learned from the HIPAA de-identification policies and procedures that are approved under HIPAA privacy rule. For this audience, I don't think I probably need to go into any great detail about the fact that we have a public policy collision course that's underway. There's a great deal of additional information that's becoming available about individuals, including information on genetics and a great variety of new data sources that we have, and at the same time we have these issues of data privacy concerns. And research done with de-identified data has it's an invaluable public good. Some examples I would include the patient-centered outcome research initiative, the Sentinel initiative from the FDA, which uses de-identified data. There are a variety of ways in which we further the public good and public health through the use of de-identified data for research. Some of you may be aware of a paper that came out in 2010 from a lawyer, Paul Ohm, called The Broken Promises of Privacy, Responding to the Surprising Failure of Anonymization. And in this paper, Paul alleged that scientists have demonstrated that they can often re-identify or de-anonymize individuals hidden in anonymized data with astonishing ease. And he purported that this amounted to a surprising failure of anonymization. I think there are two misconceptions, at least about HIPAA de-identified data. And the first would be the idea that it doesn't work. Ohm says that easy, cheap, powerful re-identification allows de-identified data to be re-identified. And I think pre-HIPAA, that perhaps was a valid argument. You may have heard the statistic before that someone's 5-digit zip code, their full date of birth, and their gender is able to re-identify 87% of the U.S. population. It turns out that through subsequent evaluations over 3 decades of the U.S. Census, that number is lower, probably 63%, but it's certainly not what we would call a very small risk and not an acceptable risk of re-identification. However, it's notable that using those same characteristics as the person who had published the result of supposed 87% re-identification, the same researcher in 2013, using 5-digit zip code, birth date, and gender, was able to re-identify in actual data, as opposed to census data, 28% of the population that she attacked. So I would purport that the reality post-HIPAA is that HIPAA-compliant de-identification does provide us some important privacy protections. And one estimate from the same author was that roughly about 4 people in 10,000 would be re-identifiable using the safe harbor criteria. Under the HIPAA de-identification requirements, re-identification should be expensive, time-consuming, require substantive computer and mathematical skills. It should rarely be successful, and it should be uncertain as to whether it's actually succeeded. At the same time, I would say that we have another misconception, and that is that de-identification could work perfectly or permanently. Perfect de-identification isn't possible. There will always be some possibility that people could be re-identified from data without direct identifiers. De-identifying data does not free data from all possible subsequent privacy concerns, and data wouldn't ever be permanently de-identified because we don't have a 100% guarantee that de-identified data would remain de-identified, because we don't know what data will become available in the future in a public form. And so we probably wouldn't have imagined 2 decades ago that nearly as much data collection from a phone device or various mechanisms through which people collect data from us on our computers would be as widely disseminated as they would be. The inconvenient truth, this is my Al Gore moment here, is that de-identification leads to information losses that can limit the usefulness of the resulting health information. And so we never achieve this ideal situation of both getting perfect information and perfect protection. It's not achievable due to just fundamental mathematical constraints. However, if you look at this trade-off curve, this is on a log scale, so moving a little bit up on the scale from the red arrow to the, or red dot to the green dot, is a substantive increase in the amount of privacy protection that can be obtained with very little loss of information. And so we try and achieve these optimal balance points in which we preserve as much utility for research as we can, and yet at the same time provide important privacy protections. And the alternative, if we try and provide 100% protection of privacy, is that we will end up in a position of making bad decisions and bad science, because unfortunately de-identification can destroy information utility. To give you some idea of the risks that are involved, this is a slide done from the 2010 census. You'll see that the re-identification risk in the population is shown on the left-hand side, where if we have a combination of full date of birth and a 5-digit zip code, along with gender, which is implied to be present in all of these measurements, we have nearly 100% re-identification risk. Because this is on a log scale, this is actually roughly about 63%, but it falls between 100% and 10% re-identification risk. Whereas if we simply move to providing the month of birth as opposed to the full day of birth with a 5-digit zip code, we now drop down below 10% and above 1%. If we further change that to the year of birth as opposed to the full date of birth and a 5-digit zip code, we're now down in the area of roughly about 1 in 1,000. These whisker plots here show you what the measurements are for the states in the United States. And so the boxes provide the boundaries on the 25 and 75th percentile, and the whiskers provide the most extreme situation for the most extreme state in the United States. If you look down at the bars that are in light green, you can see that if we have the combination of the year of birth and a 3-digit zip code, we're now down at a much lower level in the area of below, well below 1 in 10,000. And that if we move further, that's with the month of birth. If we move further into the HIPAA safe harbor year of birth and 3-digit zip code, we're now down at a virtually de minimis amount of risk. We're below 1 in a million. If we reintroduce, though, an additional quasi-identifier of adding in somebody's race, you'll see that this re-identification risk jumps up quite dramatically. So it's the full set of quasi-identifiers in combination that create the re-identification risks that we need to attend to. Unfortunately, some popular de-identification methods can degrade the accuracy of de-identified data, particularly for multivariate statistical analyses. They can do things like destroy variance-covariance matrices for regression analyses. They can mask heterogeneous subgroups that we may need to be able to detect. And while this problem is well understood by statisticians, it's not nearly so well recognized and integrated with public policy. But poorly conducted de-identification can lead us into bad science and bad decisions. You'll see here I've taken just as one example, de-identification can hide important differences. Let's say that I was trying to look at a difference over racial and ethnic characteristics, and I decided that I would only show people who are Caucasian and then any other category. There's quite a bit of statistical difference between these different categories that I'm collapsing together, and because I've collapsed them all together, I now have made the variance on the other group large. And of course, in a statistical test, we're trying to determine whether the difference is statistically significant based on the size of the variance. I've now, by grouping these heterogeneous groups together, I've made the variance so large that I wouldn't even get a significant result on the difference of white versus other. And so that's a considerable concern that we can prevent ourselves from recognizing important facts that we ought to be able to see in statistical analyses. How does re-identification occur? Well, consider a scenario, for example, where we have a voter registration list. We might have another data set in which we have names and addresses in the voter registration list, and we would have somebody's gender and their age and perhaps other characteristics that could be linked. We might take a de-identified, and I use the word de-identified only to mean stripped of direct identifiers, de-identified data sets from a health source that might have diagnosis codes or procedure codes present. And if I link those two things together, wherever I get a unique match, I would have potentially re-identified the name, address on someone with a particular diagnosis or procedure combination. The reality is that only records that are unique in both the sample and the population would be at risk of being re-identified with exact linkage. Records that aren't unique in the sample couldn't be unique in the population, and therefore they wouldn't be at a definitive risk of being re-identified. Records that are unique in the sample but which aren't unique in the larger population would match with more than one record in the population and would only have a probability of being identified. and records that are not in the sample also aren't at risk of being re-identified. It's where we have both a sample unique and a population unique at the same time where we have a risk of being re-identified. And as an example of how badly this can distort results if we don't do de-identification well, I share these slides. It's from 3 different common regression methods: linear regression, logistic regression, and proportional hazards, for 2 different types of cancer: colon cancer and lung cancer. And you'll see that the de-identification methods in some cases are creating as much as 90% of the regression coefficients changing significance. So we go from saying there's an important statistical difference here to, or there is not an important statistical difference, to reversing that state of knowledge. And so that's of great concern. If this is what we're going to do to our ability to conduct accurate research, well, then we should all just give up and go home. Poorly conducted de-identification can distort our ability to learn what is true and lead us into bad science and decisions. This doesn't need to be an inevitable outcome. Well-conducted de-identification practice always considers both the re-identification risks and works to control both statistical accuracy and re-identification risks. But doing this requires a firm understanding of a body of literature called statistical disclosure control, or statistical disclosure limitation. Data privacy concerns are far too important and complex to be summed up with the kind of catchphrases that we often hear on Twitter or in social media, saying that there's no such thing as anonymous data. Such statements are essentially meaningless or even misleading without consideration of the specific de-identification and re-identification contexts. Things like the data details, how many variables are involved, what are the resolution of their coding schemas, do they have special data properties such as geographic detail or social network properties. We also have to consider what de-identification methods were applied in the experimental design that was used for the re-identification attack demonstrations. Good public policy requires that we have reliable scientific evidence. Unfortunately, de-identification policy has often been driven largely by anecdotal and limited evidence. Often these attacks have targeted particularly vulnerable individuals, and they fail to provide us with any reliable evidence about real-world re-identification risks. So in Paul Ohm's paper, he cites the re-identification of Massachusetts Governor William Weld, the re-identification of someone out of ostensibly de-identified AOL data, and the re-identification of 2 individuals from the Netflix movie rating data. This slide, you'll want to study this in more detail than I'll be able to go through right now, but what I've done is taken 11 different re-identification attacks that were well described in the news and made headlines, and looked at whether the data was de-identified under HIPAA. Anything you see in red here wouldn't have been considered to be HIPAA de-identified. Did the individuals target a vulnerable subgroup? Did they, or conversely, did they use statistical sampling to assure that their results would be representative? How many individuals were re-identified in the attack? How many people were at risk? Some notable headlines, which I think you'll find to be quite different than the reality of the risks that I'm going to show you from these attacks. And then whether the data was against HIPAA compliant or statistically de-identified data. And so only 2 of these attacks were against data that was HIPAA de-identified, and then the risks that were demonstrated in those attacks is demonstrated. To summarize, the publicized attacks tend to be on data that is without HIPAA or statistical disclosure limitation de-identification applied. Many of these attacks were targeted only onto especially vulnerable subgroups, and they didn't use sampling to assure representative results. And the press reporting and the kind of headlines that they attach to these departs importantly from what the demonstration attacks actually showed. So an example that I think is worth noting, particularly for this audience, is the Washington State Hospital discharge attack, in which 40 individuals were re-identified out of a total of 648,000. That's roughly 1 in 16,200. It's 2.5 times lower than your lifetime risk of being hit by lightning. This is from the news report on that attack, and so newspaper reports were used to essentially know everything about the individuals, and then they were looked up in these public use data files. A similar data set, a healthcare data set with quite a large number of quasi-identifiers, was de-identified. That previous data set was not HIPAA de-identified. This next data set, the Heritage Prize, was statistically de-identified under the HIPAA expert determination method, and there were 113,000 people in the data set. A re-identification scientist was engaged to try and re-identify the data set, and they were able to re-identify no one in the data set. Another example that I mentioned earlier is the use of 5-digit zip code, gender, and date of birth, as well as embedded names. 28% of the people could be re-identified, and this would be an example of a data set. If you have a full 5-digit zip code and a full date of birth, this data set in no way is meaningfully de-identified. It wouldn't qualify under safe harbor, and it certainly wouldn't qualify under the expert determination method. So to summarize these 11 attacks, for the papers, or for the attacks that were cited in Paul Ohm's Broken Promises paper, 4 people were re-identified out of a total of 125 million, or 1.25 million individuals. For attacks against HIPAA de-identified data, 2 people were re-identified out of a total of 128,000. Both of these were adversarial attacks involving skilled data intruders teams. In both cases, I think there were teams of PhDs involved in attempting the re-identification. And for all of the attacks combined, 268 people were re-identified out of a total of 327 million opportunities for re-identification. So let's get some perspective on this. Now, hopefully everybody can see that very small black dot in the middle of the slide. And if we followed that same logic, we'd have to conclude that this slide is black because it has a black dot on it. This dot is proportional to the amount of area on the slide as the number of re-identifications that were achieved. So clearly, de-identification doesn't work. That's my tongue-in-cheek response. If that's your takeaway message, you've not heard what I'm trying to communicate to you. And the problem with this is that when a re-identification attack has been brought to life, our assessment of the probability actually occurring may subconsciously become 100% because we've just seen this occur. And so it's highly distortive of the true risk-benefit calculus that we face. What can we conclude from the empirical evidence provided by these highly influential re-identification attacks? The demonstrated re-identification proportion is extremely small, which doesn't mean that the risks are necessarily that small, but the statistical methods used in these re-identification attacks only targeting vulnerable individuals really doesn't give us a good measurement of what the risks might have been. But with only 268 re-identifications out of 327 million opportunities, I think we have to contest Paul Ohm's assertion that scientists can often re-identify with astonishing ease. That seems like a dubious claim. And it also seems clear that the state of re-identification science and the evidence that it provides needs to be dramatically improved and reevaluated. Some ways that we can not be misled when we look at re-identification attacks: look at whether the attack only was against a trivially strawman de-identified data set, meaning the direct identifiers were taken out, but they didn't use any statistical disclosure control methods, or whether it targeted only particularly vulnerable subpopulations, whether it made bad worst-case assumptions, or whether the experiments, as a corollary, flip that on its side, did the experiments actually go far enough to show the boundaries where the de-identification finally succeeded, so that we have an idea of what data is important for assisting in re-identification. Did it fail to distinguish between being unique in the sample, which of course many individuals who are unique in the sample may not be unique in the larger population? And did it correctly address the issue of re-identifiability? Just being unique is not necessarily enough to say that someone could be re-identified, because you need to link that to a population register with identifiers to re-identify those individuals. Did it specify the threat model in a way that it could be fully evaluated? And is there unrealistic emphasis on providing absolute privacy guarantees where we don't tolerate at least a very small risk of re-identification? As Sally had very helpfully pointed out before, a situation that is best for handling de-identified data is to combine both technical de-identification, making it unlikely that someone could be re-identified, and then putting in place additional technical or administrative or legal controls that help make it less likely that re-identification would even be attempted. And if we look at the probability of someone being re-identified, is broken into two parts. First, the probability that the re-identification would be attempted, and then the probability that someone would be re-identified given that they were that the attempt was made. We can see that we get some important synergy out of the process of combining these methods. If we make it less likely that people will even attempt re-identification, we've decreased the re-identification risk. And if we use technical de-identification to make it unlikely that they will succeed even if they attempt it, that creates a feedback loop to reduce the probability that they will even attempt it if they're not going to succeed. And so we can frame our probability of attempts in terms of the motivation, the resources, the data access, the attack methods that are available, what are the quasi-identifiers in the data set, how much does the data change over time. If you're using geographic information and people move, then the re-identification probabilities will be decreased. The probabilities of success, the consequences, and whether someone might have a more effective alternative way to achieve their goal. I would suggest that when you're considering putting into use protections in a data use agreement, that these are good to have in place as part of all data use agreements. The recipient should be required to not re-identify, attempt to re-identify, or allow to be re-identified any individuals or patients in the data, or their relatives, family, or household members. They should not link any other data to the data without obtaining a determination that the data would remain de-identified. They should have appropriate data security, physical, technical, and administrative safeguards so that we can have an idea of who is in possession of the data, and we have an idea of who the parties viewed as possibly being able to attempt re-identification are. And then if they're going to pass that data on to anyone else, they should pass these additional conditions on to them as part of their release of the data. There are several slides here that provide the references for that table. So when you get this, you'll be able to go through and review all of these links. And that concludes my portion of the presentation.
I want to thank both Dan and Sally, and we're now going to open up for questions. We've received a few in the chat. If you have additional questions, please feel free to add them to the chat, and I will start with the first question. How can we balance the need to protect data confidentiality with the public health and ethical need to identify health disparities among vulnerable populations that frequently are minority groups? If they are not identified, they will likely not receive the resources they need, particularly during emergency situations.
So I'd be glad to jump in on that question. I think you've hit the nail right on the head with that question. The challenge is you, if you look back at the slide that I showed as to how much re-identification risk jumped when we simply added in race, this is a really important issue. And I don't think we're necessarily in a state of ethical equipoise to be able to say, well, we have to protect privacy and that's our #1 priority. Because if we're in a position in many parts of the United States, if you're anything other than Caucasian, your re-identification risks can be importantly increased. For example, with regard to being Asian, 95% of the Asians in the United States live in metropolitan statistical areas. So if you're an Asian in a rural area, you're at a greatly heightened risk of re-identification. And yet that's, rural areas may be a place where Asians face health disparities. And so that's just one of many examples of the fact that when we do this as a public health activity, we have to balance what we're doing in terms of the public health decisions that we make and what kind of common good that we can provide to people, along with the risk that someone might be re-identified. And if we don't accept at least a very small risk, then we've put ourselves in a position of, unfortunately, probably making very bad public health decisions.
I agree completely. I think it goes back to those World Health Organization ethical principles that I mentioned in my slides, thinking about, I think, beneficence, really, our moral obligation to act for the benefit of others, for those who might be in the minority if we are not, and considering what their legitimate interests are, by preventing or removing possible harm. And so we have to balance the harm that they might be experiencing in their environment that contributes to poor health outcomes with the harm that they might experience if their health information, de-identified health information becomes re-identified. And I think that as Dan's presentation laid out so very well, that those risks are very small, increased when we're considering minority populations in areas where they are less, as Dan said. But really, it's a balancing act, and there's no way to say if our decisions are absolutely right or absolutely wrong. And so there's judgment calls in all of these decisions, but with the ultimate goal of increasing equity, increasing population health. Sally, do you have anything to add?
I think you both covered it beautifully. I couldn't say it better. Okay.
Well, I have a question now for Sally. If 42 CFR Part 2 applies to a data sharing scenario, does that mean that I do not need to review for HIPAA compliance?
Thank you. 42 CFR Part 2 that's a legal citation to the substance use and disclosure regulations. And so you can have a data sharing scenario where both 42 CFR Part 2, or Part 2 for short, and HIPAA applies, and you actually would need to comply with both for that data sharing scenario. So when you look at HIPAA, as Dan discussed, and I just touched on briefly in my slides, you can have a choice of two different ways to de-identify, either through the safe harbor standard, where you remove the 18 identifiers and also are not aware of any ability to re-identify an individual in the data, or you utilize an expert to de-identify the data set. So you can choose either one of those options, but then your question is, what do you do about Part 2? How do you meet the Part 2 requirements? And Part 2, essentially you would layer it on, and when you read the guidance around Part 2, they basically are deferring to HIPAA's de-identification requirements, and so you can rely on HIPAA and then select either safe harbor or expert method for the appropriate approach. And if you're in public health and say you have not become a hybrid entity for whatever reason, and your traditional public health programs are actually covered by HIPAA, and you must de-identify to the HIPAA standard, then you might really seriously consider selecting to go with the expert method approach. So if in a certain data sharing scenario, if it's important to the community to first and foremost have more granular date information, say a quarter instead of just a year, then you might go with the expert method. Or if it's more important to the data recipient to have county level information instead of such granular data information, then those are decisions that an expert can work through and evaluate based on the needs of the data sharing project or the community.
Thank you. Okay, another question for Daniel. Can you not just use the standard de-identification methodology of an SLK 581 for data linkage?
I'm afraid I don't know that. That reference is not familiar to me.
Okay, it's not familiar to me either. It seems that Sophie Howlett, maybe we can follow up with her outside of the webinar and get more information on that. Okay. Well, another one that I have for Dan, the HIPAA safe harbor rules requires that we not report any geography smaller than a 3-digit zip code. What can I report about the identities or locations of a patient's healthcare provider under the HIPAA de-identification rules?
So the HIPAA de-identification rule, at least the safe harbor, says nothing about the issue of whether you can or does not in any way prohibit you from identifying providers or where providers are located. The thing that needs to be recognized is that the provider's location, if you're not using the safe harbor method, does say something about where the individual is located in many circumstances, because individuals travel to see many providers, and there's kind of a tiered travel distance situation, in that they will travel further to see to seek care at a hospital. They will travel usually less far to see a specific provider. In terms of a retail pharmacy location, the travel distances in many parts of the country are extremely close. And so that's essentially giving away exactly where the patient resides. So if you've attempted to not disclose where the patient is by saying we won't tell you where in the state they are, we won't even, or maybe not even which state they're in, only what census region they're in, yet you're regularly reporting out where they've seen providers, that provider information can say much more about where the patient is likely to be located. And we call these risks geoproxy risks. And it's important to make sure that if you're not doing safe harbor and you need to assess the risk of re-identification, you need to also assess these geoproxy risks as part of your evaluation.
Thank you. I think this one may be focused to Sally. Where can I find examples or resources for administrative controls such as data use agreements?
Sure. This is a nice question. We are hosting a data summit on October 3rd and 4th in Plymouth, Michigan, and we hope we'll see a lot of you there. On October 2nd, we're also hosting 2 pre-summit workshops. The first one will focus on different agreements that we use in public health, including data sharing agreements, data use agreements, business associate agreements, so that there will be level setting around the different terms and how each one will be used. And then in the afternoon, we'll have a workshop on our new hybrid entity policy. And this workshop is tailored for anyone who hasn't done a HIPAA reassessment in the past couple of years, or if anyone is interested in reevaluating their HIPAA single covered entity status to become a hybrid entity. This might be beneficial for you.
I'll also mention that we have some sources on the network's website related to data use agreements, as well as how to analyze a data sharing issue that some people might find helpful as well. And those can be found on the network's website under the data topic. And then I think we have just, unless we get any more in the Q&A box, we have just one more question. This one's focused at Dan. You mentioned the Washington State Hospital re-identification attack. I recently read about similar attacks against public release data for hospital discharges in Maine and emergency department visits in Vermont. Can you discuss those attacks as well?
Sure. So in October of this last year, a re-identification attack was made against the Maine hospital discharge data set public use file and against a Vermont emergency department data set. It was the same sort of attack that was used against the Washington hospital discharge data set. So news reports were found that it indicated that the individual was hospitalized. Quite often it had the person's full identity, their name, exactly what had happened to them as part of the news report. And so I think there's some question, given that this is already public in the news, whether this counts as a situation in which it was the data itself that created the vulnerability. It was the news reports that were actually used. The way that this attack was implemented, there were 69 individuals out of 244 news reports, or 28.3%, in the Maine hospitalization data that could be re-identified. So 69 out of 244 hospitalization records. In Vermont, for the emergency department visits, there were 16 individuals who were re-identified out of a total of 47 newspaper reports. And the paper that was published on this reported that as a 34% re-identification attack. The reality was that in the Maine hospital discharge data set, there were over 100,000 people. There were 105,888 people in the Maine data. In the emergency department visit data in Vermont, there were 268,984 individuals. And so the re-identification rate as a proportion of the data that was released was 0.065%, or 1 in 15,000 for the Maine hospital discharge data, and 0.008%, or 1 in 13,000 in the Vermont data. So there were a total of 85 individuals in the two data sets out of 374,792 discharge records. So almost 400,000 discharges. And the risk of re-identification for being in either of those two data sets was 1 in 4,400. That's actually lower than the 1 in 2,500 re-identification risk that was cited by the same author in front of the National Committee for Vital Statistics in 2007. So this, I think, is an attempt to make it seem as if the re-identification risks are very high, and certainly if you have a news report published on you, it does look like there's the ability to find those in roughly about a third of the cases. They may be locatable inside the data set. What I should mention is that neither of these data sets were de-identified to the HIPAA de-identification standard. And so if the HIPAA safe harbor conditions had been imposed on those data sets, the re-identification estimates would have been 1 in 16,000 for the main hospital discharge data set, or 1 in nearly 54,000 for the Vermont hospital data set. These are extremely small risks, and HIPAA doesn't require no risk. It requires a very small risk. And so had the HIPAA safe harbor method been used in the release of these public data files, clearly the risks would have been very small. However, having dates more specific than the year is part of what has to get excluded by HIPAA safe harbor. And for these data sets, it's likely that we would have wanted dates more specific than the year in order to increase the utility of that data. But an expert determination method very likely could have achieved re-identification risks that were as good as were found here. And so I think we need to be cautious, as I pointed out before, on re-identification attacks that are focused only on vulnerable subpopulations. If there had been a sampling of the data in the data set and then an attempt to re-identify individuals, we would have ended up with very different results. And this was not representative of the entire population of individuals in the data sets that were released.
Thank you. We've actually had 2 more questions just come in. I think that this first one's probably focused at Sally. It says, I run a program that serves women at risk for poor infant mortality. We have a referral relationship with public legal aid. We've requested that they sign a BAA because they have requested reports and may need to determine if referrals are accurate. Legal aid believes that they do not need to sign a BAA because they do not provide medical services. We believe that they should sign in order to disclose the information. Is a signed client release sufficient?
So to evaluate if an organization is a business associate, the first question to ask is the organization, in this case legal aid, serving as or are they processing protected health information on behalf of a HIPAA-covered entity? So we heard that legal aid is receiving reports. So you would want to look at whether those reports are de-identified to the HIPAA standard, either under safe harbor or under the expert method. If they are not de-identified and the covered entity is providing legal aid with protected health information, which by definition is identifiable, and legal aid is performing a service on behalf of the covered entity, then it sounds like to me that there could be a business associate relationship in place. What you might want to do to look at a decision tree would be to go to our website under data and health information and then go to the HIPAA assessment or hybrid entity toolkit. And there's also a resource page, and there it's set up very similarly to our de-identification toolkit. You go to the resource page and you'll find several decision trees that help you evaluate whether there is actually a business associate relationship in place. So in a nutshell, it depends. It always comes back to the facts, and you'll want to evaluate those two pieces against the decision tree, whether legal aid is acting on behalf of the covered entity and whether identifiable protected health information is being sent by the covered entity to legal aid.
And Sally, if the answers to those are no, then in that case, the signed client release would be the proper course, correct? Because
That's
they
right.
would be then
Thank
giving
you,
permission for their information to be disclosed as a referral.
That's right.
Right? Yep.
That's
okay.
right. Thank you.
Yeah, and then the last question that we have seems to be focused towards Dan. Is there a 101 resource on all of this for anyone who's not in the heart of the public health science space and wants to feel more proficient about the vocabulary? I know that this is always something that I struggle with. And they said maybe that's the Office for Civil Rights FAQ you referenced, and that they said that they're probably not the only one with this question. Definitely not.
Yeah, so the November 12th, 2012 de-identification guidance from HHS is available on the HHS website. And I would say that's the place where I would suggest most people start reading. There's also a very good book on statistical confidentiality by George Duncan and Mark Elliott, that it provides an excellent overview of the area of statistical disclosure limitation. And so I would recommend both of those as resources for people who are seeking to find more material in this area. I've also got a fair amount of slides similar to the presentation that I gave today that are available publicly out on the web. And so you may find those to be helpful as well. And if you search under Barth Jones, I have the advantage of, besides my wife, having a unique last name with regard to that. So you'll find them quite quickly.
And this is Sally. I'd like to promote our new de-identification toolkit once again. We have actually a tool within the toolkit, it's towards the bottom of the web page when you scroll down, that is even more basic. It boils down the guidance that Dan referred to, as well as includes some links from NIST at a very basic level. It's written by an attorney for other attorneys and other non-statisticians. So it could be helpful in addition to the resources that Dan identified.
Great, thank you. I want to thank both Dan and Sally for their wonderful presentations today. And I'm going to pass it back to our webinar host, Charles, to give a brief announcement. Thank you.
Thank you, Jennifer, and thank you, everyone, for your participation in today's webinar. And again, thank you to our panelists for presenting today. I learned a lot, and I know our attendees did as well. So just a few final notes to all of our attendees. You will be receiving an email that will have a video playback of this webinar, as well as a link to our brief webinar survey. We really value your thoughts about today's webinar and what topics you would be interested in for future webinars. You'll also be receiving an email from ASL and me with information on how to apply for CLE credits for this webinar if applicable. Finally, if you enjoyed this webinar, just like Sally mentioned earlier, be sure to check out the 2019 Public Health Law Summit with sessions focused on data sharing to improve community health. That summit will occur in Michigan this October, and you can find more information by visiting the events page on the network's website. Also be sure to tune in to next month's webinar, The Measles Outbreak, Public Health Authority, New York City's immunization mandate, and the current legislative landscape on June 4th. It'll be one to remember. So that concludes today's webinar. Thank you all for attending and have a great rest of your day.